Director, Dr. Anuprita Dadi, General Physician and Cardio-Oncologist, Mumbai. And our chairperson is Dr. Arjun Ghosh, Cardiologist from London. So I now welcome our session director to please present her slides. Over to you, ma'am.
Good afternoon. Can you see my slides?
Yes, ma'am, we can see your slides.
So good afternoon, everybody. Welcome to the cardio-oncology session at the 47th ICON conference. And we have renowned international and national cardiologists and medical oncologists as faculty for this session discussion. So cardiovascular disease and cancer continue to be the two leading cause of death despite significant improvements in prevention, screening and treatment of both disease. And both this disease often coexist in the same individual with many shared modifiable risk factors. So focus on distinct diagnostic of cardiovascular disease and cancer with minimal therapeutic overlap and common misperception of competing risks and of reduced life expectancy in cancer patient might result in an inappropriate deferment of cardiovascular disease screening, risk factor modification, optimal cardiac treatment, and vice versa in this cohort and even in cancer survivors too. So both cardiovascular disease and cancer remain significant public health problem, growing in importance globally. And despite this threat, the fields of cardiology and oncology have been relatively disconnected. So an increased appreciation of the interaction between cardiovascular disease and cancer treatment has led to the development of new medical subspecialty, that's cardio-oncology. So generally cardio-oncology problem in patients with cancer, generally cardiovascular toxicity induced by systemic therapy like chemotherapy, targeted therapy, immunotherapy, cardiovascular toxicity caused by radiotherapy, thromboembolic complications of cancer, cardiac tumors and metastasis, underlying cardiovascular disease, cardiovascular risk factors, effects of aging in cancer patient, and cardiovascular disease in long-term cancer survival. So cardiotoxicity, even asymptomatic, so can not only negatively impact patients' cancer and cardiac outcome, but also may limit their therapeutic option, also in future too, in case if there is a relapse. So the general principle of cardio-oncology is identification and treatment of cardiovascular risk factor and pre-existing cardiovascular disease before initiation of cancer therapy with known cardiovascular toxicity profile, supporting the patient through their cancer treatment regimen with a personalized surveillance program, diagnosing and treating cardiovascular toxicity during or after cancer treatment, appropriate medium and long-term follow-up for patients with cardiovascular disease attributed to cancer therapies. And in August 2022, European Society of Cardiology, with collaboration of International Cardio-Oncology Society, have published the first guidelines on cardio-oncology. So I now request Dr. Vivek to start with the session.
Thank you, Dr. Anuprita, for a brief introduction on cardio-oncology. I would request the panelists to come over and join here. Dr. Hollis D'Souza. Dr. Hollis is a medical oncologist from Mumbai. Dr. Sandeep Ganguly. Dr. Sandeep Ganguly is a medical oncologist from Kolkata. I think I had seen Dr. Sandeep Ganguly. He is probably there in the other hall. Dr. Jaya Ghosh, madam, is missing today. Dr. Manish Kumar. And we have a cardiologist from Kolkata, Dr. Manojit Lodha. Please join us. And I will request Dr. Anuprita as well as Dr. Arjun Ghosh to be there for the session as my panelists. Okay, so to start the discussion, so Dr. Hollis, what is the percentage of your oncology patients who have cardiac disease at the baseline?
At baseline, around 20 to 30% do have some underlying cardiac disease.
Okay.
The incidence is lesser with a severe cardiac disease. You ask about diabetes, hypertension, incidence is much more. But I'll say around 20% have around baseline cardiac disease, 5 to 10% have a severe cardiac disease, IHD, with reduced CF.
Okay, but considering diabetes, let us take hypertension. Do you think it is a cardiac comorbidity? It is a cardiac disease, or you think hypertension is just like tension? You know, it is not a disease. It is like a tension. So
I won't consider it to be a cardiac disease per se, but definitely every patient hypertension, I'm sharp. Yeah.
okay. So one thing that we have to understand is that the mind of oncologist, for a mind of oncologist, the severity of the disease is like, to the tune of cancer, and hypertension is less often thought of as a disease. It is not thought of as a disease, but I mean, you take this opinion to Dr. Manojit Lodha. Probably he is a cardiologist, and it's a bread and butter for him. If you tell him that hypertension is not a cardiac disease, he must be taking it on with you, Dr. Hollis, outside this hall. So, Dr. Manojit, what do you say? Do you think hypertension is a cardiac disease?
Definitely yes.
It's a cardiac disease. Okay. Difference of opinion. Oncologists, when they are treating cancer, you see, hypertension does come in like a, not like a significant disease. So, but Dr. Manish, what is the percentage of cancer patients that you see have cardiac disease at baseline, pre-existing?
Well, if I take everything into account, right, from hypertension to ECG abnormalities, maybe some arrhythmia, say, or some LV dysfunction, it definitely should be in the range of around 15 to 20%.
20%.
Yeah,
Okay.
it should be.
Dr. Jaya, ma'am, in your clinic, what percentage of patients already have a cardiac disease?
So no, I don't think I can tell you an exact audit, but approximately if you 10 to 15% will have known cardiac risk factor. I mean, known meaning that they might have a previous history of ischemic heart disease or some valvular heart disease. But if we have to score all these cardiac, I mean, for this I was just looking up the recent ESC and the scores for cardiac risk factors, then probably the percentage of people with uncontrolled hypertension, long-standing diabetes, if you put those factors into account, then I think the percentage will be much higher, close to 30 to 40%.
It depends upon the clinic to clinic, but I guess percentage. Dr. Sandeep, in your OPD, so what is the percentage of patients who already have some cardiac disease, cardiac comorbidities?
5 to 10%.
Only 5 to 10%. So we had
It's underreported. I will be very honest. It's underreported.
Yeah. So we had an Asian Cardio Oncology survey, which was responded by 200 doctors. 40% were medical oncologists, 20 were radiation oncologists, and around 24% of the respondents were cardiologists. And when we asked that what percentage of oncology patients have cardiac disease, so you can see the responses, and 5 to 10% and 10 to 20%, this was the most common response. So probably 20% is a good figure that we can all agree on to. So 20% of our patients are already having cardiac disease. And what is the percentage of patients on anti-cancer treatment that you think that are going to develop some cardiac problems while on treatment? Dr. Sandeep, will start with you. So while on treatment, what percentage of your patients will have a cardiac problem?
It depends from cancer, the subtypes of the cancer. Like
of course, but if you have to, out of 100 patients that you are treating across various OPDs, how many patients you have to refer to a cardiologist because he has developed a cardiac problem?
again depends on the site of the type of treatment we are using. Like for
So let's see breast cancer. Let us have breast cancer. How many patients during treatment will develop a cardiac disease in your
4% to 5%.
5%. Madam, what about your?
Yeah, I think a similar number on treatment developing active cardiac dysfunction will be around, yeah, same, from 5 to 6.
Dr. Hollis and
Only
Dr.
thing
Manish.
is that, sorry.
Please
I,
continue.
yes.
Please continue.
No, I just wanted to say that, when we say on treatment which develop, so that percentage is around 4 to 5. But when you follow them up, especially
Correct.
with breast cancer, 2 to 3 years down the line, that percentage may be as high as 8 to 10% of those patients who develop cardiac dysfunction.
Cool. So on treatment, post treatment, definitely we're going to have higher. Dr. Manish, what about your experience?
So talking about in particular breast cancer, are you saying, as we all know that it all depends upon the, say, anthracycline, for example, you're using up to 300, is about, say, 2 to 5%, 2 to 3% the person who likely develop. But I would agree with Dr. Sandeep, to a large extent, it depends upon the setting where we're using, the pre-existing cardiac disorder, past history of radiation, the other history like smoking, obesity, and all the risk factors. So, and suppose we're using, say, trastuzumab, and the patient earlier who received anthracycline had some cardiac dysfunction related to anthracycline, that person is more likely to have. So, the figure can range from 2%, it can go up to 30%, depending upon the setting we're using. So, that's how it is. It's very difficult to quantify in general terms.
Yeah, so this was another same question asked to the survey, and pretty similar results of what people were agreeing that 5 to 10%, 10 to 20%, they are further going to develop cardiac. So let us start with this case, and I'll start with Hollis. Dr. Hollis, 50-year-old female, postmenopausal, no known comorbidities except COPD, and known case of right breast cancer, underwent MRM, T2N1 disease, ERPR negative, HER2/3 positive, fit patient, echo is normal. So how would you treat this patient? Adjuvant treatment, what would be your plan?
So standard 4AC, 4T, trastuzumab maintenance.
Correct.
I'm
So
not keen for TCHP.
yeah. So anthracyclines and trastuzumab and taxanes and correct. So this is what Dr. Anuprita was talking about, that the recent guidelines that has been published, and the cardio-oncology concept, where we always begin with a cardiovascular risk assessment, and then starting the oncological management, continuing monitoring and surveillance for cardiovascular disease, again ensuring that we are preventing the cardiovascular disease by prevention strategies and cardioprotective measures, and of course identifying the cardiovascular disease. We have specific definitions now of what do we consider as a cardiovascular toxicity or a cardiovascular disease due to chemotherapy, and post treatment, of course, management of cardiovascular disease with continued oncological management, and post treatment surveillance and survivorship as to identifying what Dr. Jaya was talking about, late toxicities and late cardiovascular toxicities. So this is just a similar, a chart which they have published. It's a 133 page long document which European Society of Cardiology has published. Really wonderful guidelines. So pre-chemo fitness, you have planned the treatment, but the question comes that we have to assess, because the treatment, we have to assess whether the patient is fit for this treatment or not. So, Dr. Manish, whom do you want to do this pre-treatment assessment, and what is your opinion? How will you do the pre-treatment assess?
Well, in general, we do functional assessment for all the patient, especially if the patient is of, say, more than 50 years of age, and that does include echocardiography and ECG also. Maybe suppose there's a younger patient who's, say, 35 years of age and to whom I'm planning to give gemcitabine. Obviously, I'll not send that patient for echo, but in general, yeah, functional assessment considers. And so in a scenario where I'm likely to use a drug which is known to be a cardiotoxic and patient is probably having some cardiac issue on assessment, in that case, I would like to send this patient to a cardiologist, basically to understand, does the patient need to be started on the beta blocker or ACE inhibitor, something like which can be cardioprotective. So that's how I approach.
So pre-chemo fitness for treatment, Dr. Manojit, what do you think regarding the pre-treatment cardiologic assessment? Should this be done by the oncologist? Should this be done by cardiologist? And what should be done? Should each and every patient be sent to cardiologist? You know, you are running a cardiology OPD at Tata Medical Center, which is a high volume cancer center. So, what is your opinion on this?
If there is any risk factors, suppose the patient is more than 60 years of age, or if there is any cardiovascular risk like dyslipidemia, hypertension, or any other history of ischemic heart disease, or if the patient has a family history of strong family history of coronary artery disease, or smoker. So if there are any other cardiovascular risk factors, then the assessment should be done by a cardiologist, because he can assess the cardiovascular risk factors better. And in that case, pre-op echo is also, before starting the chemotherapy, we should have a baseline echo so that we can compare the echocardiography with the ultimate. When you start the therapy, then we can follow up with the baseline chemotherapy and baseline echocardiography and see how the ejection fraction goes down. And in those patients where the borderline ejection fraction is there, I always suggest one should also go with the global longitudinal strain pattern imaging, so that if we know the GLS score at the baseline, then we can assess the GLS score later on when you start with these chemotherapeutic agents. And even before an ejection fraction drops, if the GLS score drops by more than 15%, then you can think that yes, the patient has subclinical cardiotoxicity is there, so you can start the therapies earlier.
We'll come to that. So, madam, what is your opinion? How do you select your patient for cardiology referral before starting treatment? Do you think all patients should be referred to cardiologist for pre-chemo fitness, cardiological fitness?
No,
or
I
you
don't
select
think
your patients
all
to
patients
make
will be very
referrals?
overwhelming and may not be needed. So it is just that those with a high baseline cardiac risk factors, I mean, those are the patients that we would select and definitely ask for a cardiology referral so that their cardiac function is optimized. And having said that, I would also think, that the overall onus of it lies on the treating oncologist. Like, what I just tell the residents is that, we can't send like surgeons, please give fitness for chemotherapy. The cardiologist will write back, fit for chemotherapy with due cardiac risk. So I think it is the final call has to be with a discussion with the cardiologist, and and we have to take the oncological risk factors and the cardiac risk factors in tandem before we decide what treatment to give. So
I think that is very optimal. Dr. Sandeep, your opinion on pre-treatment cardiac risk assessment?
As Joyali said, it's not for everyone. For some selected group of patients, should be done. And obviously Manojita is there, so who always helps us. It's not for a blanket for all. Like during our DM days, we used to write 2D echo.
Yeah.
That is okay, but
So what we can all agree upon is that a baseline basic risk assessment, of course, every oncologist will do as a learning that we have all learned before starting treatment as to whether the patient is fit or not. But if a patient already has cardiac comorbidities, or if we are giving a potentially cardiotoxic treatment which can result in some cardiotoxicity that is a known complication of the treatment, then I think we ought to refer to cardiologists, because they can optimize, they can evaluate better, and they can identify the patients who are really at risk for these cardiac complications. So I think and this was a survey. In our survey, baseline cardiac assessment was 70% around told that yes, it should be done for all patients, whereas 30% believe that it should be done only for those patients where cardiac risk factors or premorbidities are there. But 60% to 70% believe for all patients we have to do a baseline cardiac risk assessment.
yeah, and I can't emphasize history enough in that, because like for many of the residents, baseline cardiac risk assessment is just like checking the ECG 2D echo, but looking at the other risk factors and something that we don't often look at, like the lipid profile, a previous cardiac history is, sometimes it is looks very obvious that the patient will tell us the previous cardiac history, but sometimes you really need to dig into it before they tell you that 12 years back they had an MI and a stent. So I think those are the factors that we.
Correct. So this was also another interesting, that who should do the cardiac assessment, and in our survey, the 33% told that no, we should send to cardiologist for risk assessment, whereas 63% believed that both oncologists and cardiologists can do, whoever gets the patient first can do, but 33% believed that only cardiologists should do the assessment. So how we do the baseline risk, I think Dr. Manojit was initially only telling that we should know regarding the current disease, whether there is any disease or not, and what was the risk factors, cardiovascular risk factors, which includes age itself, family history of cardiovascular disease, presence of diabetes, hypertension, hypercholesterolemia, and lifestyle risk factors like smoking, alcohol, obesity, sedentary habits. All these come into the risk factors also. And of course, what previous treatment that patient has received, whether they are cardiotoxic or not, previous radiotherapy, previous use of anthracyclines, all this. And coming to pre-treatment evaluation, again, I think Dr. Manojit already told regarding the echocardiography and the quantitative evaluation of ejection fraction, as well as all these factors that need to come into ECG. Of course, the QTC interval that we need to look into, even if the patient is having normal ECG. And this is something, again, has not been so equally and documented everywhere that we see. So these are the basic tests. So I would ask Dr. Hollis, who does the echocardiography at your center?
So the cardiologist, he is a trained cardiologist. He does the echo at our place.
Okay, and is GLS routinely reported, or do you ask for it, or have you ever asked for it?
Asked only for one patient till now. He is post-anthra induced cardiotoxicity, but not for all patients who I'm planning for anthra or trasto. Okay. Not for all.
Okay, Dr. Manish, what is who does the echocardiography?
Yeah, cardiologist. Generally, we send the patient to cardiologist only. And GLS very rarely. I mean, I can't remember that last time when I asked for it. So, and baseline cardiac marker, nowadays I have started getting NT-proBNP done in some of our patients, where I feel, because I feel it's a good marker. So otherwise, echo and ECG is something that I ask for the cardiologist.
Yeah. So Dr. Manojit, I mean, you must have been doing the cardiac risk assessment and echocardiography. So do you do the GLS regularly? What is the challenge regarding doing GLS just as a
actually, in Tata Medical Center, GLS, the software is not available. So in Tata Medical Center, we are not doing. But in other hospital where I am attached, it is Ramakrishna Mission Seva Pratishthan, there we routinely do GLS. Even to identify ischemic heart disease in early stages, we go with the GLS score. So GLS is done in RKM routinely, but in Tata Medical Center the software is still not available. I think GLS will take time to evolve, because in most of the centers still the software is not available, or the cardiologists are not yet trained. It is a relatively new thing. So in coming years, I do really believe that GLS will become routine in echocardiography part. So specifically in cancer chemotherapy patients and on those where we are expecting some ischemic heart disease. So in those cases, GLS is going to be the routine investigation. So probably next 2-3 years, we are hoping to do that routinely.
Dr. Ranade wants to speak.
Nobody's talking about
Muga. Okay. So I think I'll bring in. Yeah. So. So I think let Dr. Manojit, he is the cardiologist, yes. So he should answer whether Muga does really have an advantage.
Yes, Muga is much more objective as compared to the echocardiography. I must say that echocardiography is still subjective, specifically the ejection fraction measurement in echocardiography are mostly subjective. So with individual, varies from individual to individual the ejection fraction measurement. So in that case, Muga is okay. But in those patients where normal ejection fraction is there, we are not doing it routinely, and because Muga is most costly and less available. So MUGA is not for the routine investigation. Echocardiography you can do routinely and you can repeat it at times you want. So MUGA, to do repeated MUGA is not possible. So in that case, I will prefer to go with the echocardiography with the same individual repeating the test, because that will become more objective. Rather than doing it in different centers, repeating the echo in the same center with the same cardiologist will probably give you better results.
I'm going to ask you a question which you're not going to like. Very often the technician does the 2D echo, right? And very often, I'm not saying at your place. And cardiologists opine on it. So is it okay that the same technician has done it and the same cardiologist has reviewed it? Will it be better than, rather than having someone else?
It's better.
Yeah. So this was Dr. Ranade was talking about. We also asked in our survey, and 32% reported that actually the echocardiography is not done by the cardiologist himself, and it is actually an eco-trained personnel. You can. It's not a technician, but he is a eco-trained MBBS or a eco-trained MD. Who does the echocardiography rather than a cardiologist? 32% responded this.
What I think they do nowadays is somebody does it, actually the procedure, and it is reviewed by a cardiologist.
Yeah, yeah. So that.
Only the images are reviewed.
Yeah. So this is also one of the challenges. I'll bring in Dr. Arjun Ghosh, who's joined virtually from London. Arjun, what is your opinion regarding the MUGA scan, as Dr. Manojit was talking and it was asked? So do you think in routine pre-cardiac assessment, where does MUGA stand, and what are the advantages and disadvantages as compared to the traditional echocardiogram?
Thanks, Vivek. Thanks to the organizers for this invitation. So if you look at the ESC guidelines, and even if you look at the guidelines that we wrote nationally, MUGA is a test which is reproducible, but that's the only advantage. Apart from that, there's no advantage. With an echocardiogram, again, it has to be a well-performed echocardiogram. The reason why in the ESC guidelines, in the national UK guidelines, and in most of the guidelines, so we've recently written guidelines from the American College of Cardiology, which will be coming out this year. It has to be a 3D ejection fraction. That's the ideal. Now, I appreciate that not every center will have 3D, but then if it's a 2D, it should be a biplane. It should be well assessed. You should use contrast if you can't get accurate images, and that is more reproducible. Now, with GLS, as mentioned, the combination of GLS and ejection fraction together gives a better estimation. And the other thing also to remember is there are lots of patients we've seen previously who've been having ejection fractions with MUGA. Ejection fraction is actually going up. And the reason it's going up and the patient is getting more short of breath is because the patient has got mitral regurgitation and the ejection fraction keeps going up. Now, the patient doesn't understand why am I getting more short of breath when the ejection fraction is still fine and I'm getting my breast cancer treatment. So echocardiogram gives much more information than just an ejection fraction. You get an assessment of the valves, you get an assessment of diastolic function. So it's a comprehensive evaluation, which is why, again, if I bring it back to the recent guidelines, these are the first international comprehensive guidelines. MUGA is really low down on the risk. The first test is an echo, again, quality echo with 3D and GLS if available. Second is actually cardiac MRI if you can't get good echo images. And after that is actually MUGA. Now, MUGA, there has a role in some patients, but in our practice, and I appreciate that it's different in different places across the world, we don't use it at all.
So I think I may not be incorrect if I say that if you are ordering MUGA, that means you are not relying your cardiologist or you are not relying on the echo report. So that means that you don't have the faith on the quality of the echo if you are ordering MUGA. Other than that, there should not be any reason why MUGA should be ordered.
No,
Correct?
I think echo is there is an inter-observer variability. Now the question is, is the same cardiologist going to be doing the echo at every study that you're going to do? Or is it a different person? So there is bound to be a variation in that.
Yeah. So Arjun, your comments on that. Most oncologists feel that echo may be done by different cardiologists, or different people are doing the echo, and there is an inter-observer variation. So that is why echo is not that reliable. So how do you counter this argument? And is it possible for the same person or the same cardiologist to do the echo again and again? In practical world, it is probably not that possible.
Yeah, so absolutely, we have to take into account what is the weakness of echo, and even the same cardiologist doing the same echo in the same patient, one day apart, they will get different values, and that's just one of the weaknesses of echo. However, there's a lot of data to show that 3D ejection fraction is actually very comparable to cardiac MRI reproducibility. So cardiac MRI reproducibility is superior to MUGA. Now, again, with all the guidelines, they always state that it should be high quality echo. Now, if you're saying that it's poor quality echo versus MUGA, that's a different situation. Then, for the oncologist, they would rather have more accurate value, and that might be from the MUGA. So I think the point is not to say, which is more reproducible. The point is to say that we should be aiming for high quality reproducible echocardiography, because that doesn't give radiation to the patients. It's more widely available, and you can get more information.
Correct. So there, sir, that with coming of age with 3D echo, with GLS, from my institute, they give you CD of that echo that is being done. So all these factors taken into account removes that inter-observer variability. It is more reliable, and the CD can be interpreted by another cardiologist, and he can produce the same figures again. I would bring in Dr. Anuprita. Dr. Anuprita, is GLS routinely reported, at TMH? Dr. Anuprita has joined virtually. So, Dr. Anuprita, do you report GLS for each and every patient in where you do echo?
Again, GLS, you need a good echo window, and also it has to be done on the same machine every time. So with our patient, when in between they're going outside for echo or somebody else is doing, following up with GLS is very difficult. Also, you need to have a baseline GLS when you're starting for a cardiotoxic to follow up with what. Once the EF is down, and then you do GLS and follow up. So if you're aiming for a cardiotoxic chemotherapy, and you are known that patient will be following at your center throughout, then you can start with the baseline GLS, and plus it should have good echo window. We generally don't advise MUGA scan. We generally, if there is a very poor echo window where we're not able to assess LV function, then only we advise, because again, follow-up with MUGA is difficult because the patient is going to expose with radiation. And as Dr. Arjun said, we are not going to get extra information with MUGA scan. But radiation is also, exposure is also there. So again, it has to be done on the same machine. Is what is the issue with the GLS? But wherever it's we get a patient where we could follow, we generally follow up with GLS if we have a baseline thing right at the beginning.
Yeah. So Arjun, what we are seeing in India is that we are definitely facing this challenge of getting GLS done, because as Dr. Anuprita said that it has to be done on the same machine. Dr. Manojit said that the software is not available. He's been working with a high volume cancer center, and in my hospital also there are 3 echocardiography machines in the room, but only one has the software for GLS. And these are practical challenges that are there with us, why we can't perform GLS and why we don't have GLS. What is the situation in UK and the rest of the world? Do you do GLS in your center for each and every patient, or you also pick up the patient for which you need to do GLS while you leave others?
Sure. So I think it's different across the world. So I mean, I'm lucky. I work in Europe's largest cardiac center, so all of our patients have GLS. They have 3D if the image quality is available. But I think that we have to be realistic. We have to be practical, and not every hospital, every machine has GLS and things. But the useful, I mean, coming back to the guidelines again, the use of having such guidelines is you can take the guidelines to the management and say, look, these are the international standards. This is what's recommended. We really should try to get to these standards. And, you know, this is what it says in the guidelines. And we should try to get the GLS, because at the moment, you know, GLS on echo machines, you know, has been available for around, you know, 8-10 years. So it's pretty routine now for the machines to have it. It's not a new thing. It's not something that, you know, it is pretty routine. So my comment would be that we should really try and engage with the management to try and get these, you know, machines with, you know, GLS in all of our institutions. And the second thing, as I mentioned, is that even if GLS is not available, we should definitely aim for a good biplane, you know, 2D estimation. It shouldn't be visual estimation. It shouldn't be TICOLs. And if we can't get biplane, we should give some sonoview. We should give some contrast so we can get an accurate estimation. That is the only way, because we have to give confidence to the patient and to the oncologist that whatever value we give is an accurate value and a good representation. We've already discussed about the variability, which is definitely a problem. So the only way that we can give confidence to the patient and the oncologist is if we perform the echo to the best of our ability. So if there's no GLS, if there's no 3D, we must try and get a biplane. We must try and give sonoview, give contrast. And if it's not possible, then we look for alternative imaging.
Yeah, I totally agree, because the 3D echo with GLS which I order just costs you know, my patient 1,000 or 1,500 bucks more, but it's totally more reliable, and you have the GLS and it is readily available. So you know, this is one take home message that we should all carry, that we must request our management and cardiology team to have the updated 3D echo with GLS, which is the high quality echo. And you know, which is towards the standard of reporting, where GLS is also mentioned, because once your patient has cardiotoxicity and the ejection fraction is already low, then there is no point of doing GLS. Whereas you can identify those patients who have a minimal, you know, drop in their GLS, and you can identify those toxicities before your ejection fraction drops in. Yeah, yes ma'am, you wanted to say something.
Yeah, I just wanted to add that, of course, having it at baseline and following up would be ideal. But what if you're not able to reach that ideal, what we usually do is, like, you know, patient, say on maintenance trastuzumab, has some shortness of breath. Ejection fraction was 54%, and now it's 52, 50. So that is when we kind of at least order in these patients which are borderline.
Correct.
One, and, you know, repeat another and repeat the GLS. So then we have two of these, and even if you're not able to do it for all, for at least some of these borderline patients, we do ask.
Yes,
So
that is what the point is, ma'am, that we must utilize the availability of GLS which is there, as well as the availability of biomarkers. If we are doing biomarkers at baseline and you get a similar situation like yours in OPD, where your patient has some minimal cardiac symptoms and you do biomarkers, you know, if the biomarkers are elevated, that you know that there is some cardiotoxicity happening because of which this is happening. And if we are not doing the routine biomarkers for these patients, then we are going to miss it, because if we don't have a baseline, then you don't know whether this elevated report was there at the baseline or not. So for our patients who have high risk of cardiotoxicity because of the treatment, or they have a baseline cardiac disease, in these patients especially, we ought to do the biomarkers. This is what, you know, I believe.
So, but I would like your opinion, because if routinely for everybody receiving anthracyclines, I think biomarkers will not be of probably help, because not shown much of benefit, but probably with somebody who has an underlying cardiac disease.
So if there are risk factors, or Suppose we are using the anthracycline in higher dose, we are planning to do anthracycline in higher dose, then probably baseline is equal. But if we are using the anthracycline in a lower dose, suppose less than 200 or 300 milligram per meter square, then probably we can avoid the.
So I would just ask Arjun also. Arjun, can you comment, in your hospital, do you do biomarker for each and every patient who would receive trastuzumab or who would receive anthracyclines?
No, I don't think you do, and I don't think you need to. So I think, very much as the panelists have said, you need to identify those patients who are high risk. And again, coming back to the guidelines, which are very comprehensive, there's a very nice flow chart I think you showed at the beginning, or Anuprita showed in one of her slides, that how you can risk assess the patients, and the basic risk assessment is actually very good, very comprehensive, and can be very useful. So, and it's not, all you need to do in the basic risk assessment, is there a cardiac history? Do you have high blood pressure? What is the blood pressure? What is the lipid profile? Are you a smoker? So some very basic things. It's not expensive. It's not difficult. It does take some time because there are 2 or 3 questions and you have to check the blood pressure. If on that basis, if they don't have a previous cardiac history, if they have no cardiac symptoms, their risk is on the lower side, and then they can follow the algorithm of the low risk patient. However, if they are in the medium risk or the high risk, and the International Cardio-Oncology Society and the European Society of Cardiology published in 2020 a risk scoring algorithm for common treatments, for anthracyclines, for MEK inhibitors, for VEGF inhibitors, for Herceptin. So if you risk score these patients and identify the low risk patient, they can continue. They don't need any special monitoring. If they are moderate risk, yes, you do need monitoring. They may need biomarker monitoring. They may need referral to cardiology, and the high risk patients, they do. So I think that the guidelines from 2020, the guidelines from last month, they nicely show the different algorithms. So as you said, it's a long document, 133 pages. There's lots of tables. You don't have to go through all of that. Next month, the ESC will publish a handbook, which is an abridged version of the guidelines. So that handbook can be used by non-specialists. It can be used also by patients. So a handbook is being published that will be coming out next month. So that will give a very good guide for the commonly used cardiotoxicities and how to assess them.
So this is the proforma for anthracycline chemotherapy baseline risk assessment, which I took from the guidelines. And you can see that for all the risk factors they have given scores, and you can do a scoring, and then you can see whether your patient falls in the high risk category, medium risk category, very high, or whether it is low. And then as per this scoring and risk stratification, they have given what are the investigations that you have to do and whether you need to do biomarkers or not. And similarly, just as Arjun was saying, you have this for every treatment, and for HER2 targeted therapy also you have a similar risk scoring that you can do, and then you can clearly. But the point is that in a busy oncology OPD, how many times do you think will you be able to do such objective risk scoring? Dr. Ganguly.
Sorry, I won't be able to do it.
So do you think a specialty cardio-oncology clinic will help you to do these risk scorings and tell you which patient is your high risk? Will that help in your practice?
In a small volume center it's feasible, but not in a high volume center, because the cardiologists will be more motivated, don't take me wrong, they will be more motivated doing interventional and rather than calculating scores and all those things.
So these are objective scores. I mean, an MBBS student can only do this scoring and inform you what are the
Issue, like if the technician is doing a echo, we are having an issue, but how can a MBBS doctor can assess?
No, this is a basic risk scoring that needs to be done.
For that, the MBBS doctor is so good, I believe.
Yeah.
I think even if you do, even if you don't do, the exact complete scoring, I think, a basic history and, just 4 or 5, like was also mentioned by Dr. Arjun, just basic history of diabetes, like whether the hypertension is uncontrolled. You just take a history, somebody is diabetic for 3 years versus somebody who is on, 3 anti-diabetics, is on insulin, has some end organ damage, already has CKD. So those are the kind of, subtle things which you will have. So if you just have a checklist of, some of these factors, and of course having that entire checklist would be good, but even these basic checklists to be ticked off, I think will give you, and then those who are at least falling in, and then you really want to decide whether to avoid anthracycline or not. And I think that situation, having this objective score would be very useful, rather than, doing it as a routine, for a 30-year-old who's non-diabetic, non-hypertensive, I'm not going to do this scoring. But for a 50-year-old diabetic, hypertensive for the last 5 or 6 years, and creatinine of 1.1, and I'm thinking has a 3 centimeter node negative tumor, whether I should avoid anthracycline, that is a time probably I will do this comprehensive risk assessment.
Yeah. Dr. Monojit, a fit patient plan to start anthracyclines, do you think we need to initiate cardioprotective measures in this patient, or you think that just monitoring or surveillance is enough?
Yeah, if the risk factors are there, we should, modifiable risk factors are there, we should modify those. Otherwise, we don't need any intervention like beta blocker or ACE inhibitor, not.
Okay, and if the patient on baseline cardiac risk assessment is a higher risk for cardiotoxicity, then do you think we need to initiate? So when is the time you think you should initiate cardioprotective measures, and what cardioprotective measures are we looking into? Looking at preventing anthracycline related cardiotoxicity.
So the most important thing is the dose actually. So we have to monitor the cardiotoxicity by, if the patient are at risk, then we probably require more frequent echocardiographies. So we should know, when we are starting anthracycline therapy, then we should decide at which which interval we will do the surveillance echocardiography. At the baseline, we should always assess the risk factors. If the risk factors are modifiable, then we will modify. If the ejection fraction is normal and if there is no specific risk factors, then we should think that at which doses we will do the surveillance echocardiography. Suppose a patient doesn't have any risk factors, so then probably if we are giving anthracycline and the dose of 240 milligram per meter square, if more than that, then at that time we require to do a echocardiography, and after that, after every 3 cycles, we have to repeat the echocardiography. So we should decide when we are going to do the echocardiography. Beforehand, we start the therapy. But otherwise, to start with a beta blocker or ACE inhibitor without any with normal ejection fraction, no, we don't have to start.
Okay. Again, Dr. Anuprita, so how do we identify patients? Should we wait for the ejection fraction to drop before we start the cardioprotective measures, or how to identify these patients early, and to start the cardioprotective measures? Because again, is starting early good, or we need to wait for the the cardiotoxicity to happen and then start these prevention strategies?
So Dr. Vivek, my worry is not about the patient who are already having cardiovascular disease, because they are already on some kind of beta blockers, ACE inhibitors and all. My worry is patient who is diagnosed with hypertension, diabetes at the time of diagnosis of cancer, because this patient are unaware of they are having, how long they are having, how that. Optimizing this patient during the course is very important, because what happens is, further, if you don't address or you don't educate those patients, further what happens is, in between he lands up into some cardiotoxicity, there is interruption which we need to avoid here. So those are the concerns, those are the group of the patient which needs to be addressed properly, who needs to be educated, and then they are having some fear, like my treatment will get delayed, or there will be I will be denied of treatment. In those patients, your risk assessment, your patient discussion, giving time to patients, starting with cardioprotective is must. With cardiovascular risk factors or cardiovascular disease, patients are already on medicines. You need to, if they're not, or if you need to optimize it, you need to start correct, like ACE inhibitors or beta blocker, wherever the patient is not, you can shift. Most of the patients on calcium channel blockers, and you can shuffle those things. Those patients are not, because they know, they're aware. But the patient who are diagnosed with cardiovascular issues during the cancer are the patients which are worrisome for me.
Yeah, Arjun, what is your thought? Patient has normal ejection fraction, we are monitoring, and patient is on anthracycline treatment. when do you want the cardioprotective measures to start? I mean, when the ejection fraction drops down, then only, or you have early indicators, and is there a benefit of starting early?
Yes, that's a, I think, very, very good question and very, very interesting question. So I think I agree with what's been said before. We wouldn't routinely start ACE and beta blockers. However, again, if you look at the guidelines, they do suggest that ACE and beta blockers can be given prophylactically in some high-risk patients. And again, we're coming back to that high-risk situation. So if the patient is very high risk from a cardiac point of view, and if everything is very borderline, so if the ejection fraction is borderline, rather than starting treatment initially, maybe what you might do is actually monitor them more closely. What we find is those patients who've received, say, multiple lines of treatment before, and then they are again developing a new cancer, they've had, say, previous anthracycline exposure, they're going to go above the threshold of maybe 300 milligrams, exposure, or they've had radiotherapy. And in those situations where you know that you will be giving a lot of cardiotoxic treatment, you may consider it. But again, however, this is, the situation where GLS plays a role. We were talking about GLS as an earlier marker of abnormal toxicity. So if the if the ejection fraction is normal in this patient, definitely you would recommend doing ejection fraction GLS monitoring more closely. And here also biomarkers have a role. So, you should be considering, if the patient is very high risk, to be doing biomarkers with every cycle or biomarkers every 2 cycles, because if that goes up, then you should consider maybe cardioprotection. So there's lots of other things to consider, like GLS biomarkers in this situation.
Another issue, so suppose this patient, this patient was given anthracyclines, and post anthracyclines, actually patient landed up with a ejection fraction of 45%, So now you want to give trastuzumab to this patient, and how would you approach this patient? Dr. Ganguly, what would you do? So you started patient on, can somebody give him? So you have reassessed, and now patient has less ejection fraction.
I will ask our cardiologist Monojita for a fitness. If he gives, I will. If it does not, I will stop. But
so in this today's era of cardio-oncology, so that is what our objective is, to give potentially cardiotoxic treatment to a patient who is at high risk of cardiotoxicity. So if Dr. Manojit says that no, patient is not fit for
he
trastuzumab,
says that,
what will you do?
He sometimes say avoid, but sometimes he says that close monitoring. For some patients, recurrent disease, we have given trastuzumab even with the ejection fraction of 45%. But every 3 weeks when the patient used to come, we used to get the echo done and ask her symptoms. And obviously the cardiac medications were going on. So
yeah, Dr. Hollis, what will you do in this situation?
Yes,
Patient needs to be given trastuzumab, but now has a less ejection fraction. So
maybe around 40, I'll still continue trastuzumab. I can't omit trastuzumab maybe in a adjuvant setting or a metastatic setting. Regular monitoring with each and every dose, but trastuzumab needs to be given. So
and regular monitoring means
before every cycle.
Before every cycle.
For every dose of trastuzumab.
Okay. And what will you do? Echo or biomarkers or both?
Echo and biomarkers, maybe not GLS because it's difficult in my setting.
Yeah. Dr. Jaya and Dr. Manish, again, not a very uncommon situation. But
yeah, I mean, I would always be very skeptical before using trastuzumab if the LVF is less than 50% going by the guidelines. But I would agree with other panelists that, it is one drug which you don't want to, say miss. And it's a very important drug. So even at say 40-45%, one can consider if it's in a very pressing situation. But I'll monitor with a standard way, echo or MUGA, whichever is possible. But only thing is that in this subset of patient, if I have, normally we see that if you have to hold trastuzumab twice, then you permanently omit it. But in this subset of patient, if I have to hold even once, I'll discontinue. I'll not give it a second try. That's the only difference I'll make.
Jaya, ma'am.
So I think suppose the ejection fraction is 40 to 45%, and there are studies which have shown that trastuzumab can be given, and we do also give, especially if it is in the adjuvant setting, with, as was mentioned by all, with close monitoring. And this is a patient where would not want to consider a shorter course trastuzumab. say for just 6 months and rather than continuing. So taking all things into account.
Short course is the way to go. Dr. Manojit, final comment as to how Dr. Sandeep has referred this patient to you. Now, how would you give fitness? I mean, it is a quite niche, like just a surgeon referring to anesthetist for pre-anesthetic fitness, and oncologist referring to cardiology for fitness for. Correct. So how would you handle this referral, and how will you manage this patient?
Actually, I will discuss, usually I routinely discuss with my oncologist how much benefit you are going to expect. Suppose it is in a metastatic therapy, HER2 receptor positive, and you are going to get benefit from the trastuzumab, then I would like to say to continue with trastuzumab with full dose of carvedilol and ACE inhibitor in the background, if required, even aldosterone antagonist, MR antagonist. And if the patient is symptomatic or not, these things are important. If the patient is in overt congestive heart failure, then most of the time I would suggest to withhold that therapy. If the patient is not in overt congestive heart failure, if the patient doesn't have any overt symptoms of signs of heart failure, then we can continue till the ejection fraction is 40%. So in those cases, if the patient is asymptomatic, if the patient has a metastatic breast CA, HER2 receptor positive, we would still like to continue with the Herceptin with monitoring of LV ejection fraction probably every alternate cycle.
Yeah. So I think very aptly said that we need to consider clinically whether the patient is actually in heart failure or not. And if the patient is not in heart failure with adequate monitoring and cardioprotection, we can continue potentially cardiotoxic treatment. I would thank my panelists for this wonderful session, and also thank Dr. Anuprita and Dr. Arjun Ghosh to be there, and back to the organizers. Thank you.
Thank you so much, sir. We'll now move on to our next session, which is the oral paper competition finals. I now invite our judges to please come on stage. I invite Dr. Sanjay Desai, surgical oncologist from Indore, Dr. Chirag Desai, medical oncologist from Ahmedabad, and Dr. J.P. Agarwala, radiation oncologist from Mumbai. So till Sanjay sir joins us, we'll just explain the rules. 5 oral presentations have been shortlisted. Each participant will get about 6 minutes for presentation and 4 minutes for audience question and answers. So we'll call upon our first abstract presenter. Our first abstract presenter is Dr. Alak Ananda Chaudhary, and her abstract is Comparison of Setup Errors Between Two Immobilization Techniques for Image-Guided Pelvic Radiotherapy. Over to you, ma'am.
Good afternoon, everyone. So today my topic of presentation is comparison of setup errors between two immobilization devices for image-guided pelvic radiotherapy, where the cost of positioning and immobilization can be used, reduced without compromising treatment. So the objective of a radiation oncologist is to deliver therapeutic radiation to the target area as accurately as planned, more so with the advent of conformal radiotherapy techniques. However, we need to reduce the we need to avoid geometric target miss. For that, we need to add a PTV margin. However, a large PTV margin will lead to increased irradiation of the surrounding organs at risk. Pelvic malignancies have reported large set of variations, and thus good treatment techniques like positioning and immobilization are advocated. So here we have compared two immobilization devices, that is the pelvic thermoplastic cast and the ankle fixation device, and to compare the translational mean setup error produced by two different immobilization techniques, and to compute the CTV-PTV margins to find out whether we can use the ankle fixation device as a more cost-effective alternative. So this is a cross-sectional study done at the Department of Radiotherapy Medical College, where we have considered biopsy-proven cases of pelvic malignancy between 2018 and 2021. We have included cases with malignancies of the urinary bladder, cervix, prostate, rectum and endometrium requiring definitive radiation therapy. Using either of the two immobilization techniques discussed and immobilization being done in the supine position, we have excluded malignancies pertaining to any other subsite of the pelvis or radiation therapy with palliative intent, immobilization done using any other device or in any other position. So on the day of CT simulation, the patient is immobilized on the CT simulation couch using either a 4-clamp pelvic thermoplastic cast or an ankle fixation device without the cast. Thereafter, CT scans are taken with 3 mm slices. The region of interest will vary based on the subsite, but usually it is 10 cm above umbilicus up to mid-thigh. Then the CT scans are verified for any rotational component. Thereafter, they are transferred to the treatment planning station, and contouring is done, followed by treatment planning done by 3D CRT, IMRT or VMAT technique. So on the day of setup, that is on the first day of treatment, a patient is set up on the Linac couch in the exact same position using same immobilization technique. Matching of the skin tattoos and the cast markings with the external room lasers is done. Translational shifts are applied to match treatment and machine isocenter. Then verification scans are taken. They are reconstructed into a 3D image and registered with the CT simulation dataset. Translational setup errors are calculated, applied only if deemed satisfactory, and then the treatment is delivered. These verification scans are taken for 3 consecutive days of treatment initially, and then once weekly thereafter as per institutional protocol. So this is the CBCT image being taken, and this is the these are showing the parameters of the KB-CBCT and this is where the image has already been taken, the CBCT image, and this is prior to registration with the CT simulation dataset. So data on patient particulars, immobilization technique and patient records are collected from the hospital records. Mean and standard deviation of all individual shifts, the mean translational shifts in 2 arms, population, systematic and random error are calculated. So we have there are 2 types of setup errors, that is systematic error and random error. And we have calculated the CTV to PTV margin here using the Van Haak's formula as shown. So coming to the results, this table is showing the characteristics of our study population, where we have considered 855 total number of verification scans. So this graph is showing the average setup error, average translational errors from patients in all the 3 axes. And this is a table showing the mean error in the translational axis and the mean systematic and random errors. Here we find that the CTV to PTV margin is maximum in the longitudinal direction, that is 0.93 centimeter, which means that if we are to give a uniform margin around our CTV, then a 0.93 centimeter margin is at least necessary. So this is a table showing comparison of 2 immobilization techniques in terms of the mean, systematic and random errors, and here we find that the mean error between our 2 arms is not significantly different in any of the axes. Also the CTV to PTV margin has been calculated, and the maximum PTV margin is shown, and this is needed to be applied around the CTV for creating a uniform PTV margin. Here we have shown the percentage of patients in each arm showing shift of 0.5 centimeter, more than 0.5 centimeter, and a vertical shift. More than 0.5 centimeter, it is more in the ankle fixation arm than the thermoplastic cast arm. Graph showing the same. And then a similar study has been done by Anand et al. And they have found both the devices to be equally effective in pelvic immobilization. Limitations of our study, like small sample size, inability to use the 6-clamp thermoplastic cast, intrafraction shifts have not been evaluated, and variation tumor locations have not been accounted for. So we have found from our study that ankle fixed immobilization is an effective alternative to thermoplastic cast, and it's a cost-effective approach as well. Thank you.
What is your cost of an ankle immobilization device?
So, ankle immobilization device, so it roughly, around 5,000, 6,000. I'm not exactly aware of the price, but it can be used for several years on several patients.
Even the thermoplastic, many of the centers reuse it.
Yes, sir, they do reuse it, which ideally shouldn't be the case. That is number one. And why I have said cost-effective approach is basically because one thermoplastic mask, it costs around 6,000 to 8,000 rupees in Indian rupee.
So your ankle is also costing 5,000 to 6,000.
Yes, sir, but the ankle fixation device, it can be used on several patients. It's a universal kind of a device, can be reused. It's not for a single patient. That's what I mean to say.
If you are getting a vacuum around the ankle, or you can traction it. Otherwise,